Hello, everyone. As part of our Clinical Foundations webinar series, I'd like to thank you for joining us online today for this very special educational live broadcast. My name is Emily Eberly with Sachs Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar, High Flow Nasal Cannula Therapy, a Simple and Effective Modality. To all of our guests online, I welcome each and every one of you to this webinar. During our time together today, we will focus on the mechanisms of high-flow nasal cannulas, the potential benefits, various patient scenarios, and the recommended management of high-flow nasal cannulas. And here's a big thank you to Teleflex Medical, who is our sponsor for today's program, and I'd like to welcome Kelly McGrew from Teleflex, who is with us today. Hello, Kelly. How are you?
Good. Good morning. Good afternoon. My name is Kelly McGrew, and I am the Manager of Clinical Support and Education at Teleflex. On behalf of Teleflex, I want to thank you for joining us for our Clinical Foundations webinar series focusing on current evidence-based topics for the healthcare professional. The title of today's webinar is High Flow Nasal Cannula Therapy, a Simple and Effective Modality. I would like to introduce you to our moderator for this webinar, David Vines, who will introduce you to our speaker, Megan Dubowski. David Vines is Chair, Department of Cardiopulmonary Science at Rush University in Chicago, Illinois. Before that, he held a number of appointments at Rush University and the University of Texas Health Science Center in San Antonio, Texas. He has over 23 awards and honors for his teaching, scholarship, and service functions. He has a long list of teaching credits and has published extensively in many peer-reviewed journals, as well as authored and co-authored several books and chapters. A highly sought-after speaker, David Vines has presented at numerous national and international conferences. David?
Thank you, Kelly. Thanks to Teleflex for your support for today's webinar. Our speaker today is Megan Dubowski. Megan is a colleague and assistant professor in the Department of Cardiopulmonary Sciences at Rush University Medical Center in Chicago, Illinois. She manages respiratory care and pulmonary services at Rush Oak Park Hospital, which is a community hospital approximately 10 miles from the medical center. Megan is responsible for planning, organizing, and directing activities of the respiratory care department and pulmonary rehab at Rush Oak Park. She's also involved in teaching in a number of research projects here at Rush. Megan earned her master's degree in respiratory care and has a number of other credentials, including her registered respiratory therapist, adult critical care specialist, neonatal pediatric specialist, and certified asthma educator. The disclosures for today is there is some sponsored research from Aerogen and Halyard that we currently have going, and I do some consulting for Teleflex, and today's presentation is sponsored by Teleflex. At the end of today, you'll be able to collect your 1 hour of continuing education credits, either your CRCEs or your CNEs. And at the end, we'll provide you with a URL that you'll be able to log on, complete a post-test and the evaluation. And then when you do that, you'll be able to print your certificate. Megan will be speaking to you today about an important topic, the use of high-flow nasal cannula in the acute care setting. Back several years ago, we had little data available to assist with its use clinically. As you will find out in Megan's review of the literature, that has changed. High-flow nasal cannula is considered a first-line intervention for the management of hypoxic respiratory failure patients. Megan will take it from here and explain the mechanisms of action, recommended settings, and other uses in the acute care setting. Megan.
Thank you for the kind introduction, David. I'm thrilled to join you all today and talk about one of my favorite devices, the heated high-flow nasal cannula. So let's get started. Our goal is at the end of this presentation, you will be able to explain the potential mechanisms of action of high-flow nasal cannula, discuss its use in various patient conditions, and to describe the recommended application and management of high-flow nasal cannula. So in order to get started, we need to go back to the basics, the 3 main goals of oxygen therapy. Number 1, to reverse hypoxemia, which is a low partial pressure of oxygen in the arterial blood. We want to maintain a PaO2 of at least 60 millimeters of mercury. I want you to keep in mind that this is normal based on the age of the patient, which is often overlooked. At 60 years of age, the PaO2 should be approximately 85 millimeters of mercury in a normal condition. PaO2 of 60 corresponds to an oxygen saturation of approximately 90%. We also want to decrease work of breathing, which is the amount of force that's needed to move volume into the lung with a relaxed chest wall. Remember that during normal quiet breathing, inhalation is active and exhalation is passive, so you don't have to think about it. Any deviation from that norm creates work. So if you think of patients that have stiff lungs, like in pulmonary fibrosis or even atelectasis, they'll typically assume a rapid shallow breathing pattern. They minimize the work needed to overcome that elastic resistance by taking smaller tidal volumes at a higher frequency. Their minute ventilation typically stays the same, but they have higher work of breathing. Or at the opposite end of the spectrum is increased resistance, like in COPD. Patients will slow their rate, but take larger volumes more slowly and exhale with pursed lips, minimizing the airway resistance. Minute ventilation will typically stay the same, but again, they have increased work of breathing. And the third thing that we want to do is decrease cardiac workload. The heart's trying to compensate for hypoxemia by increasing output. We want to reduce that. Oxygen therapy is indicated for documented and suspected hypoxemia. Moderate hypoxemia that requires oxygen therapy is documented by a PaO2 of less than 60 millimeters of mercury or an arterial oxygen saturation of less than 90%. Other indications include severe trauma, acute myocardial infarction, and post-op anesthesia recovery. In patients with chronic obstructive pulmonary disease and CO2 retention, low-flow oxygen therapy is indicated when the PaO2 is less than 55 millimeters of mercury or a SAT less than 88% at rest, or less than 60 millimeters of mercury and a SAT less than 89% in the presence of cor pulmonale. Oxygen therapy also may be indicated to support the patient with chronic lung disease during exercise. There's a large population of these patients that we're now seeing in our pulmonary rehab. We need to understand the root causes of hypoxemia to know how to reverse it, or even if we can reverse it. There's 5 main causes of hypoxemia. Obviously, we're going to go back to Egan's here. So number 1, a low fraction of inspired oxygen. That's when the inspired air has a reduced oxygen content. You could think of this like in a high altitude situation. Hypoventilation. That's an insufficient gas exchange. So for some reason, there's a decreased respiratory rate from a drug overdose or brain injury. Oxygen therapy is not the appropriate treatment for inadequate alveolar ventilation like this. You need to treat the underlying cause and focus on your airway protection with this. Patients who don't ventilate do not oxygenate, something to keep in mind. One of the third causes of hypoxemia, ventilation perfusion mismatch, and that's kind of the Mac Daddy, if you will. I'm going to get onto that on the next slide. Shunting, simply put, is the mixing of oxygenated and deoxygenated blood. This can be from intrapulmonary or extrapulmonary causes. Then you also see diffusion impairments. They're often found in patients with interstitial lung disease where thickening or scarring of the interstitium will hamper normal gas exchange. So VQ mismatch, it does respond to oxygen. A good reminder about this is the distribution of inspired air and pulmonary blood flow in a normal, let's say quote unquote normal or healthy people, are not uniform or proportionate to each other. There is always a slight variation in ventilation perfusion. In this picture, you're reminded that the pulmonary system is a low pressure system which allows gravity to be a powerful force. The perfusion at the bases, or also known as zone 3, is better than the ventilation. VQ is low, and there would be high blood flow, but low ventilation creating a lower PaO2. The perfusion in the apex of the lung, or zone 1, is poor. However, the ventilation is great, creating a high PaO2. When these come together, they balance each other out to give us a normal and a healthy individual. But the lung is a heterogeneous place, and that is magnified in disorders listed. Refractory hypoxemia occurs when arterial hypoxemia is essentially unaffected by an increase in oxygen concentration. The goal with this is always to reestablish ventilation without injury, and usually requires positive pressure ventilation or some kind of PEEP to reestablish functional residual capacity. So severe hypoxemia often results in the following signs and symptoms. severe dyspnea, cyanosis, tachycardia, hypertension, confusion, blurred vision, impaired judgment, and in the late stages you might see irregular respirations, bradycardia, hypotension, and coma. If it's not corrected, respiratory or cardiac arrest may soon follow. Don't forget the simple little things. Remember, a simple cough is one of the most common signs of pulmonary disease. Let's get into our bread and butter. I want you to think about the patient brought to the emergency department in respiratory distress. How do you decide what you're going to do? How do you decide what's next? There are three things to always think about. One is purpose, one is patient, and one is performance. So what is purpose? What are you trying to do? What are you dealing with? Are you dealing with hypoxemia? Are you dealing with hypercarbia? Are they coming in and they're tripoding and they have increased work of breathing? What is the purpose? What do you need to deal with? Who is your patient? Are they awake? Are they alert? Do they have COPD? Are they talking? Are they expressing fear? Do they have facial trauma? So getting an overall look at your patient is going to help with device selection. And the third thing you look at is performance. What's in your arsenal and what can it do? So if they have mild hypoxemia, a nasal cannula might do. Hypercarbic and obtunded patient, I think that they bought themselves an endotracheal tube. Increased work of breathing, what can you do? High minute ventilation with mild to moderate hypoxemia, what are you going to do? And so this is where it's so important that you understand the performance of your equipment. So low flow versus high flow devices, or fixed versus variable performance. Let's break these things down. When using low flow oxygen therapy devices, the goal is to return to a saturation of 92 to 98% for most patients, except for those who have CO2 retention. Low flow oxygen therapy devices do not provide enough flow to meet the patient's entire inspiratory demands. So FiO2 will depend based on the patient's ventilatory pattern. High respiratory rates and large tidal volumes will decrease the delivered FiO2 with a low flow device. A high flow or fixed performance device, like what you see on the right, provides a high FiO2 at or above the inspiratory flow demand of your patient. High concentration, high flow devices also are needed if the documented PaO2 is less than 60 with a SAT less than 90, and that remains despite the fact that you're delivering an FiO2 of more than 40%. These devices include a large volume nebulizer, high flow, high FiO2 air entrainment nebulizers, and high flow nasal cannulas. So stop and ask yourself a couple of performance questions before you're choosing the device. What goal are you trying to achieve with your oxygenation? How much oxygen can your device deliver? And if your patient's demand changes, is that going to be okay? Are you going to put something on them and they're rapidly changing before your eyes and you're going to go have to get a second device? So you got to start thinking that way. And if the patient has a high demand, will entrainment of room air cause them to desat? So getting into the performance. When looking at device performance, you can ask yourself a couple of questions. How much oxygen can the device deliver, and will that be enough if your patient's demand is changing? Let's start with the nasal cannula. Oxygen is provided through standard nasal cannula at flow rates up to 8 liters per minute, and FiO2 ranges from 24 to 40%, maybe a little more in adults. As a general rule, FiO2 is thought to increase by approximately 4% for each liter that you increase in oxygen flow. At 6 liters per minute, the patient is thought to receive approximately 40% oxygen. However, variations in patients' breathing patterns result in variable FiO2 delivery. The nasal cannula does remain the device of choice for most patients. It's well tolerated, it's easy to use, it's inexpensive, it allows them to eat and drink and communicate freely. Nasal dryness and bleeding can occur, but are usually relieved when you add a bubbler. High flow nasal cannulas, so we're talking about non-heated, now go from 6 to 15 liters as well, and those are great for people with a higher flow need. Simple masks are used when nasal cannulas are not tolerated, as well as in emergency situations or recovery rooms to provide a moderate FiO2 for a short period of time. The masks are quickly and easily applied and are inexpensive, but they can be uncomfortable. They can prevent someone from eating or drinking, and they can also block vomitus. A non-rebreather mask has a one-way valve over the reservoir bag on one or both of the mask ports to increase the delivery of FiO2 to 60 to 80% at oxygen flow rates of 10 liters or more. Non-rebreathing masks are inexpensive, they're easy to apply and use, and they're frequently used in emergency situations to provide a high FiO2 quickly. They can also be used for specialty gases which makes them handy, such as Heliox when a patient has upper airway obstructions. So let's get into the high flow devices. A high FiO2 air entrainment nebulizer can be used to meet a patient's inspiratory demands at high FiO2s. This device can deliver a flow of up to 80 liters per minute at an FiO2 of 60% and 42 liters at an FiO2 of 96%. High flows are achieved by increasing the diameter of the jet gas. It has been reported that this device delivers a stable FiO2 of 60 to 75% in subjects breathing normally. But that becomes variable when the device is set on a higher FiO2 or when minute volume is large. Some disadvantages of air entrainment nebulizers include them being uncomfortable. As we all know, they're noisy. You can hear them down the hall, and they need to be removed if the patient wants to eat. There's also an increased risk of infection because you are using water. And then we've got the heated high flow nasal cannula. We're going to get into more detail about that in just a minute. So what qualifies a device to be called or termed high flow? A system should provide at least 60 liters per minute total flow. Average adult peak inspiratory flow during tidal ventilation is approximately 3 times minute ventilation. 20 liters per minute is close to the upper limit of a sustainable minute ventilation for those who are ill, who are sick. So if you do the math, 3 times a minute ventilation of 20 or 60 liters per minute should suffice in most situations. So let's get into the device that you are here for. The high flow nasal cannula system. It combines an air and oxygen blender with an active humidity system, allowing for independent control of temperature, independent control of FiO2, and of gas flow rates ranging from 2 to 8 liters per minute in infants and 16 to 60 liters per minute in adults, which is what we're going to focus on here. The FiO2 can be adjusted from 21 to 100%. One of the biggest benefits of the high flow nasal cannula is comfort. It has a low profile. It doesn't weigh a lot, and it allows the patient to talk, to eat, and to drink. And I think all of us that work with patients know that comfort equals compliance. Anything we can do to keep the device on the patient as long as possible is what is good for the patient and good for us as well. How does the high flow nasal cannula work? There's 4 key principles that we're going to address. Number 1, flushing of anatomical dead space. 2, meeting the flow demands. 3, maximizing lung mechanics like heat and humidity, and then improving metabolic expenditure. So the work being done, like we discussed earlier, the work being done by the patient. The washout of expired CO2 from anatomical dead space is reported as one of the primary mechanisms adding to the success of this device. Reducing the fraction of inspired CO2 allows more oxygen to participate in gas exchange and lowers minute ventilation needs. This may result in decreased respiratory rate or tidal volume, and then that subsequently results in less work of breathing. You will see a patient kind of settle down when you do this and when you get this right. Multiple animal studies and clinical trials have reported a reduction in PaCO2, tidal volume, minute ventilation, and dead space with the use of the high flow nasal cannula. As we discussed previously, when a device delivers 60 liters per minute or higher, the device is considered to be delivering a fixed FiO2 because the air entrainment is minimized. Entrainment will obviously be maximized when the mouth is closed. And all I got to say about that is good luck with that, keeping their mouth closed. I know how hard that is when you're really trying to do that and achieve what you want to achieve. So how do you know when you've met a patient's flow demands? And I think we've all been there too, where you put the device on, you step back out of their vision, and you watch the respiratory rate on the monitor. And the patient, what you're wanting to see is that respiratory rate go down. You're wanting to see the work go down and them kind of settle in as you titrate the flow to a level that is appropriate for them. Cool thing about this device is also you can ask them, how are you feeling? How does that feel for you? Improved secretion clearance and patient comfort are extremely important. When we give patients unconditioned medical gas, it moves the isothermic saturation boundary further down the respiratory tract. This shift can damage ciliary function. It dehydrates the mucosal tissue and creates retention of secretions. Studies evaluating gas humidification in human airway epithelial cells found an increase in inflammatory markers following just 8 hours of low humidity. So just 8 short hours, they saw an increase in inflammatory markers. It's really something to think about. Numerous studies have also offered subjective data stating patients better tolerate the high-flow nasal cannula compared to other devices. And comfort often leads to compliance. And in patients refusing to wear oxygen or a non-invasive mask, the high-flow nasal cannula is a good option. If you're in doubt about how cool dry medical gases are, try wearing a room air nasal cannula for a few hours and see how it feels. I've actually done that, and it is actually quite uncomfortable, so it's something to think about. And our final mechanism of action that we're going to discuss involves metabolic expenditure. So decreasing the energy used by the respiratory muscles to breathe and the upper airway to condition the gases is our ultimate goal. When we meet the flow demands of the patient, less time is spent working and then energy is conserved. The nasal passage does a great job of heating and humidifying under normal conditions, but that system is stressed, it's taxed when cold, dry medical gas is administered. This issue is resolved with the use of heated and humidified high-flow nasal cannula, and by doing that, the patient is able to conserve energy and use the energy to heal, to do what else they need to do. So we're going to get into some clinical indications. Just straight indications. So we want the patient spontaneously breathing, obviously. High oxygen or flow requirements, you see them come in, they're desatting, they're working. This would be a good device. Moderate to severe hypoxemia and increased work of breathing. Contraindications, this won't work well for people with a nasal passage abnormalities. Do not put the device on someone who is apneic, and hypercapnic respiratory failure requiring mechanical ventilation. This was not what you want to use. Let's get into some of the recent literature on acute hypoxemic respiratory failure, post-cardiac surgery, post-extubation, DNI, heart failure, and COPD. The first study that we have deals with hypoxemic respiratory failure, or type 1 failure, a failure to oxygenate. The Florali study was published in the New England Journal of Medicine in 2015. This randomized control trial enrolled 310 subjects and was designed to assess outcomes when comparing high-flow nasal cannula, which was started at 50 liters per minute and 100%, non-invasive ventilation, which targeted 7 to 10 mLs per kg predicted body weight, and standard oxygen therapy via non-rebreather at 10 liters per minute in patients with acute respiratory failure caused predominantly by pneumonia. All 3 arms were titrated to maintain a minimum saturation of 92%. Subjects were not hypercarbic and had a P to F ratio of less than or equal to 300 on enrollment. The primary outcome they were looking at was intubation rate, which trended lower in the high-flow nasal cannula group. High flow did significantly increase the number of vent-free days at day 28, reduced 90-day mortality, and was associated with less respiratory discomfort and dyspnea. All in all, the high-flow nasal cannula was found to be safe and effective in this patient population. Post-op respiratory failure commonly requires mechanical ventilation. This population accounts for around 20% of the patients who are receiving ventilatory support. Use of non-invasive ventilation is what we normally do to help facilitate early extubation in these patients. Stefan and colleagues reported the results of a large multi-center randomized trial looking at whether high-flow nasal cannula was inferior to non-invasive ventilation in preventing or resolving post-op acute respiratory failure. They randomized 1-to-1 to either receive high-flow nasal cannula continuously or non-invasive for an average of 6 hours per day. Primary outcomes they were looking at in this study were treatment failure, which was defined as reintubation, crossover to the other study treatment, or premature discontinuation of treatment. Of note, subjects were not hypercarbic, and the average PaCO2 was approximately 39. And with similar outcomes on all measures in this study, the authors concluded that high-flow nasal cannula was not inferior to the non-invasive in this patient population. This is also known as the BIPOP study. As we all know, oxygen is commonly used after extubation, and there are several devices available to do this. Hernandez and colleagues designed a large multi-center randomized clinical trial conducted in 7 ICUs in Spain. The participants were 527 adult patients at low risk for reintubation who fulfilled criteria for a planned extubation. These patients were randomized to either high-flow nasal cannula or conventional oxygen therapy, and they could use either a nasal cannula or a non-rebreather for 24 hours after extubation. The primary outcome was reintubation within 72 hours, and they also explored numerous other secondary outcomes. Reintubation within 72 hours was less common in the high-flow group, and post-extubation respiratory failure was less common in the high-flow group. No adverse effects were reported, and authors concluded that use of high-flow nasal cannula reduced the risk of reintubation in this population. The Majore study compared the effects of the Venturi mask compared to the high-flow nasal cannula for 48 hours post-extubation. They concluded that high-flow nasal cannula resulted in better oxygenation for the same set FiO2 after extubation. Use of the high-flow nasal cannula was associated with better comfort, fewer DSATs, and interface displacements. They left it on their face. They also had a lower reintubation rate. And I think that intubation and extubation are great places to use high-flow nasal cannula because it is so low profile that you can have it in place during both. There's essentially no dead time while you're switching devices, so you can place it in the nares and either place the tube or pull the tube, and you've already got what you need in place and already set up. And in a controlled environment, if you can do that, it's really handy. One of the more difficult situations that we all run into as clinicians is the do not intubate patient who is also in respiratory failure. Oftentimes these patients are treated with non-invasive. Dr. Peters and colleagues out of the Mayo Clinic conducted a retrospective study on 50 subjects, and what they were assessing was the efficacy of high-flow nasal cannula in the do not intubate patient with hypoxemic respiratory distress. They excluded extremely hypercarbic patients and had a primary endpoint set as the need for escalation to non-invasive ventilation. They found that saturations increased and respiratory rates decreased while on high-flow nasal cannula. 9 of their 50 subjects did escalate to non-invasive, but that left 82%, a large majority, on the high-flow nasal cannula. They concluded high-flow nasal cannula provided adequate oxygenation in this population. And I really like using this device with this patient population. Even if you have to toggle back and forth between high-flow nasal cannula and a non-invasive device, you're giving the face a break and the patient can speak to their loved ones, get a drink, get a sip, do the things they need to do. And when they're more comfortable, you'll see them actually settle in and do better in that process. So in heart failure, CPAP is often used in these patients to increase intrathoracic pressures, which reduces the left vent preload and afterload. Roca and colleagues conducted a small prospective study to see if high-flow nasal cannula could do the same thing. They took 10 adults. All of them had New York Heart Association Class 3 heart failure and ejection fractions of 45% or less. Study staff used transesophageal echocardiograms, TEE, to measure inspiratory collapse of the inferior vena cava. And that collapse of the inferior vena cava was used as a surrogate for preload. High-flow room air gas was administered through nasal cannula at 3 different flow rates. So their baseline was 0 liters per minute. They took their measures. And then they also compared that to 20 and 40 liters per minute. A reduction of greater than 20% in estimated inspiratory collapse of the IVC from baseline was considered clinically significant in this study. Median IVC collapse significantly decreased from baseline to 20 liters per minute, and then again decreased to 40 liters per minute. And this represented a mean reduction of 20% from the baseline, which was significant in this study. These changes in the IVC collapse were reversible after high-flow nasal cannula was removed. Respiratory rate was also significantly reduced. So it was 23 breaths per minute at baseline with a flow of 0, and then it went to 17 breaths per minute at 20 liters, and then further reduced 13 breaths with 40 liters per minute. Their findings suggested that patients with heart failure may benefit from high-flow nasal cannula supportive therapy. Let's get into some newer publications in the COPD population. This study was conducted to assess the impact of different flow rates on ventilatory parameters in patients with severe COPD. The aim was to characterize flow-dependent changes in breathing mechanics and PCO2 when comparing high-flow nasal cannula to nasal CPAP and nasal BiPAP. High-flow nasal cannula resulted in a minor flow-dependent increase in the mean airway pressure. Tidal volumes increased, respiratory rate decreased. The calculated minute volume decreased with high-flow nasal cannula, and in spite of this fact, hypercapnia decreased with increasing flow. Additionally, an improvement in dyspnea was observed. It was concluded in this study that high-flow nasal cannula led to a reduction in PCO2 that was likely achieved by the washout, as we discussed earlier, of the respiratory tract, and a functional reduction in dead space. High-flow nasal cannula enhanced effectiveness of breathing in patients with COPD and reduced PCO2 and work of breathing in this study. So we're going to continue on with another COPD study. Patients with COPD use long-term oxygen therapy for more than 15 hours per day and have documented improved outcomes. So there's literature on this. As we discussed earlier, cold, dry medical gases can damage mucociliary performance. So Fraser and colleagues designed a randomized crossover study with the aim of characterizing flow-dependent changes in mean airway pressures, tidal volumes, respiratory rate, and partial pressure of CO2. They had 30 males who were chronically treated with 2 to 4 liters per minute nasal cannulas. So these people were on home oxygen at 2 to 4 liters per minute nasal cannula. And they brought them in and got baseline measures and then put them on high-flow nasal cannula at 30 liters per minute and compared their outcomes. So the results when comparing high-flow nasal cannula with LTOT, so long-term oxygen therapy, was the transcutaneous carbon dioxide decreased with the high flow, the transcutaneous oxygen increased with the high flow, respiratory rates were lower on high flow, and tidal volumes and inexpiratory lung volumes were higher. These outcomes were favorable for stable home oxygen dependent male, the stable home oxygen dependent male with COPD. There is also a plethora of other studies that support high-flow nasal cannula use in IPF, in emergency departments, in bronchoscopy, and just an overall quality of life. We're not going to get into all of those right now, but I just want to let you know that those are out there. There's a lot of data coming out right now. What we are going to get into, though, is the clinical application. So how do we use this device? How do we apply it? And nasal prong sizing is so important. Regardless of which product you're using, there's always a sizing tool. So make sure that you're familiar with it, and make sure that you're auditing that that's actually what's happening so that the device is being used appropriately, and there's manufacturer's guidelines for each of these. Typically, you want the diameter of the nasal prongs to take half of the patient's nostril for adequate delivery. So how do you set this thing up? There's very little that you actually have to set up, which is what I think makes it such a simple and effective device. So where we start our flows is around 30 liters per minute and titrate up. People start, in the literature, they typically started between 30 and 50 liters per minute, and what they did was titrate in response to the respiratory rate or work of breathing. So they'll start them and they'll kind of watch for 5 minutes and maybe start them at 30, and then they'll go up by 5s until they see them settle in. Or you'll see the respiratory rate drop and the work of breathing go down. We start our oxygen at 100% and then titrate, targeting a saturation goal of 92 to 98%. Obviously, you don't want to do this in your COPD or retainers patients. You want to start at 50% or less and titrate, targeting a saturation goal of 90 to 92% or whatever's been ordered, but that's patient specific. So these are really the two things that you're working with this device. Is you're setting up that flow, titrating to respiratory rate and work of breathing, or you're setting that oxygen and you're backing off or titrating up as needed based on O2 saturation. It's quite a simple device to use. So to wrap this up, use of the high flow nasal cannula in the adult patient population continues to evolve. Patient tolerance is pivotal in the increased usage, and this is likely due to the small size of that interface and the heated humidified gas. It's more comfortable. Independent titration of oxygen and flow make the high flow nasal cannula a really valuable tool in many different patient conditions, as I hope I've shown you. Beyond hypoxemic respiratory failure, where it was initially and traditionally used, there's starting to be data for its use in many other patient populations. So I want to thank you for your attention, and I want to remind everybody that you will receive an email with the URL in it to log in and complete the post-test. And now David and I are going to open up to any questions that you guys have been asking, and we'll turn it back over to David.
Thanks, Megan. That's a great job reviewing the literature and talking about some of the applications here. So we have a question here from Carl that says that we have several physicians that are afraid to use the high flow nasal cannula due to the possibility of pneumothoraces. And so in your review of the literature, he's asking here, can we get some help with resources for education on the issue? And what experience have you seen, or in your experience here, with pneumothorax? And they've only seen these in pediatric populations, which I believe is common or has been reported in the literature, right?
Right. I did not actually in the adult population find these instances, so I don't have literature to point to, but would be happy to help find resources in the peds population.
Okay, so maybe we can follow up here if you with either of the companies, whichever company you use, that has some resources on that. Carl would be able to give you those studies and then follow up with them. I guess one of the size you need to be careful is the sizing of the nasal cannula, which Megan pointed out becomes real important. If you actually occlude the nares and the kid closes their mouth, you're more likely to have these pneumothoraces occur, versus you always want to make sure that there's some clearance there around the tube and the nasal nair, so that that's your path of least resistance and the patients can exhale around them. And so we have another question here on a topic that probably deserves some discussion too, from Nick. And so one is, he says, what's the indication of high flow nasal cannula over BiPAP or CPAP? And you know, those things are clearly different. And so maybe you want to first talk about, Megan, can you actually get CPAP with high flow nasal cannulas?
Yeah, actually, let's call it PEP. Let's talk about PEP. There are some great studies out there, and this might be a place for who asked this question to go look. Groves and Tobin and Park have done a lot of work looking at PEP. So I'll just kind of go over a little high level what Parks has found. In 2011, they looked at 15 adult post-op cardiac surgery patients, and what they found was, as they increased flow rates, so they went from 30 to 40 to 50, they measured and they did get an airway pressure with the mouth closed. So I'm always going to give you mouth closed and mouth open. With the mouth closed at 30, they got around 2 centimeters of water pressure. At a flow rate of 40 liters per minute, they got around 2.5 centimeters of water pressure, and around 50 liters per minute, they got over 3. centimeters of water pressure, and those are all kind of halved, if you will, when the mouth is open. There's also some other studies in healthy adults from Groves in 2007 where they says, keep in mind these are healthy adults sitting upright in the perfect condition and setting for this, but they assessed with the mouth closed at flow rates of 40, they were getting around 5 centimeters of water pressure, which is substantial. When the mouth opened, that would drop by about half, and they got around 2.2 centimeters of water pressure. But so there is some effect of PEP. I'm not saying that you're going to get those levels like you're getting with their CPAP or BiPAP and pressure changes, but there is some positive expiratory pressure that is happening.
Yeah, so I guess the point, especially in pediatrics, you may be more likely, depending on the size that the nares occlude, right? And you're more likely with higher flows in that group developing a continuous positive airway pressure, perhaps. But in adults, generally it is, as you're saying, it's PEP, right? Positive expiratory pressure that they exhale against it that happens. And if the mouth is open, you know, the path of least resistance is out the mouth, it would be unusual to create anything other than a very, very low pressure whenever they're exhaling. And so back to the rest of Nick's question here is that when you think then that there is some, since we may have some PEP develop in these patients with this hypoxic respiratory failure, Nick, in this first line treatment in mild to moderate hypoxemic patient, it appears that high flow nasal cannula is superior perhaps in that group to what is BiPAP in preventing some of the intubations and is thought to be the first line. Would you agree there, Megan?
Yeah, I would agree, and I think that a lot of that is, as I kept saying, it's the compliance. If they're going to keep it on and you can get them to settle in and keep their mouth closed, then you actually they're seeing better results with this.
And then, you know, to finish up this question on the CPAP, if these patients here are fluid overloaded and not maintaining their saturations, then you're going to have to put a continuous positive airway pressure in place. And there in the literature, there's some reported signs of failure for these hypoxic respiratory patients. And if you initiate high flow nasal cannula and you see that the saturations, the pulse oxes or blood gases, PO2s, are dropping, are not improving, you see that respiratory rates are increasing, and you see worsening or developing of paradoxical breathing, then clearly you need to move on to other therapy. And in my opinion, this BiPAP, if they already have a respiratory failure component of hypercapnic, then you're going to get very little benefit in removing CO2 from washing out the upper trachea. You will get some. And these patients who are in hypercapnic respiratory failure, that's a different situation. And BiPAP, of course, with its inspiratory pressure would be indicated there first. You agree, Megan?
Yeah, I absolutely do agree. I think that one thing is if these people are coming into your, let's say, emergency department, a great thing to do is actually try high flow nasal cannula, and that way they're able to communicate with you and you're actively doing something to where you can get their H&P, do an assessment, and actually ask them questions, and then you know if you need to switch over if they stay hypercapnic, and you need to move on to the next step. But at least you were actively doing something while transitioning to what you needed to get to, and I think that that's an important thing too, is being able to have them speak to you.
So we have a question here from Tim, and it goes, there's talk at our facility to use high flow nasal cannula in the ED instead of BiPAP for patients that have an increased WOB or work of breathing. Have you seen this starting to be used more in the ED? I think, just Tim, to answer quickly here, that is, the earlier the intervention, probably the better the benefit here when you're talking about these hypoxic respiratory failure patients. The longer the wait, the longer you let them work, the more likely they are to end up in failure. Megan, you have anything to add there?
Absolutely. Love it in the emergency department because it's, if you will, it's so quick to slap on. It's really easy to set up and use quickly, and there is some literature out on that. It's from 2012. Langlet has a study out on the feasibility of using it in the emergency department, if you want to look that up. Replacing BiPAP, I don't want to go that far, but yes, using it while you're getting the patient kind of settle in, absolutely.
And we have a question here from John. John wants to know, can't you use high flows with a non-rebreathing mask and do the same thing? Megan, you want to?
Not high enough. So potentially that will meet if you had someone who was smaller, who didn't have larger tidal volumes, who wasn't working as hard. But for a majority of patients, they're going to need more flow than that, what you're going to max out on 15 liters basically with your non-rebreather if they're working hard.
So I guess the only thing I'd add here, John, is that you know, that non-rebreather is not heated and humidified, right? And you start turning up flows of, you know, if you figure out how to get it to stay on the flow meter at 40 liters a minute. And I know there's some brands out there that will let you do that, and our job's not to talk about brands here really. But if you try to use a mask to provide 40 liters, yes, I've done some testing to tell you it will flush out CO2, but you're going to lose all those other benefits of giving a patient a dry gas. You may worsen the situation and retain secretions. Not only worsening the situation and retain secretions and the lack of humidification and increased patient compliance or tolerance of the device there, if this doesn't flow into the nose, then, you know, I know this is a little controversial, but the creation of PEP may be an important component as this continues to get flushed out. And there's some papers you can pull looking at this expiratory pressure and its occurrence there. And so I think removing this interaction of the humidification through the nose and the mask itself, then patients will not be able to eat or drink. Just to add some more things there to what Megan was telling you. Okay, we have a question here from Pamela, Megan. It says, with the addition of flow in the high flow nasal cannula, how do you know it's safe for the patient to eat? Is there concern with them aspiration? Has this been studied? Did you see anything regarding that in the literature?
I did not, and I have had this exact conversation with one of my colleagues. There is not literature out there on this topic, but many people are chattering about this, about getting the data on this, especially if you think about it, if you have a flow of 50 liters per minute and they're drinking, not even just eating, but drinking is the risk for aspiration of just simple fluids. I have actually looked and have not found anything as of yet, but common sense would dictate that there could be some. I think I would leave it at that. I really have actually looked for this data. Did not find any yet.
Okay, so we have another question here from Dorita that says that if you're titrating the flow, you will meet their demands when the work of breathing. Will you meet their demands when the work of breathing increases?
When titrating, so we're saying they're going one way and you're trying to catch them, I think is the question. Yes, to a point. I think that's understanding kind of what we were talking about, the performance of the device. So if you've got someone who is, let's say, 6'5", with a large demand, once you get up to that high, that 60 liters per minute, that is one of those places, if you're chasing them and they're still working and things aren't going the right way, where you might be looking at doing something else. So there is always a maximum on any of these devices, and so you need to know when you've hit it, what's your next step, is kind of how I would address that question.
Yeah, and I think that, clearly people think that once you reach this flow of 60 liters a minute, it is generally meets most patients' demands because it is a continuous flow of 60 liters a minute. But certainly at some point at peak flows, patients with severe distress may exceed that, and but generally what you're looking for, as Megan was talking about and did a good job describing in the setup, is that if we typically start at 30 liters a minute and then we begin to work all the way up to 50 or 60 liters as long as the patient will tolerate the flow, and we look at their level of respiratory distress and we keep working the flow up until we start to see them begin to decrease their respiratory rate or their work of breathing goes down. And that's basically the titration up in that. And so will there be patients that will continue to exceed it? Yes, but if their saturation improves and their respiratory rate begins to drop, then give it some time and see if they will begin to ease that. Some of that's around hypoxemia, right? So if hypoxemia is elevating the drive, if you give them enough oxygen on 100% to start, so unless you're COPD, where you would worry about the worsening of VQ matching if giving them too high of FiO2 and an acute elevation in CO2, in this case, you would want to start them on 100% at 30 liters a minute, begin to work up, and watching their respiratory rate and saturation. And if you meet their oxygenation requirements and their stat starts pushing up into the mid-90s, you will watch that drive drop in my experience, and patients will tolerate it better. All right, we have another question here from Lynn. It says some patients complain about 37 degrees being too hot and uncomfortable. So how low can you go on the humidity or on the temperature?
Well, yeah, I'm kind of laughing as I answer this because, yeah, I've experienced that as well. So why do we do the 37? Let's do that first. Why do we do that? We're emulating the body's temperature and the humidity that basically we want to match, which should make it more comfortable. If we're matching what's in the body, there shouldn't be a huge difference or variation, so we should be more comfortable. So we do get the patients, and it really truly depends on which device you have, how low you can go. I know some of them just have one or two settings, 37, 31, and you can go down basically. You could also, let's say you had someone that was febrile and complaining. You could, on some of the devices, actually turn it off and use it in a passover mode for a little while. But typically, we want to leave it as close to body temperature and 100% humidity as possible. But I understand what you're saying. And in those patients, if you're at risk of them taking the device off, I would do something to titrate that temperature down for a little while until they're a little more comfortable, because you want them to keep it on.
Great. We have time here maybe for finish up one more question here, maybe a quick one or two.
Pardon me,
Jeff,
David?
And Jeff asked.
We can go over time by 3 minutes if that's okay with you.
Okay.
Sure.
Jeff asked here, is it better to start high-flow nasal cannula with patients and then titrate down, meaning starting at a higher point and then titrating down? And is there a great starting point, say 30 liters or higher, as starting for patients and then moving on when we're talking about this? So, I mean, Megan may have a different answer here, but I would tell you, Jeff, that we find that starting lower at 30 liters a minute just to help patients get acclimated to the high flow temperature and so forth, and then begin to work up to their tolerance point. And really, that's just to try to increase compliance. Clearly, we want to try in these, especially hypoxic respiratory failure patients, post-extubation, and maybe even some of your fluid overload. If you're using them there, you want the higher flows, as appears to be better. Megan, you have any
No, I completely agree with you, and I think what I've found is that if you do start them at 30 or 35, they don't actually notice when you start titrating up once they get initially set in at that 30. So if you step around the corner and they can't see you and you're watching them, that might be a place where you're able to titrate up a little bit if they're not dropping their respiratory rate, and not be in their face and telling them about it to where they're focused on it. So you might be able to titrate up without them noticing once they get used to the device.
Excellent. All right, we also had a question here. Does this mean that high flow nasal cannula has the ability to ventilate, not only to oxygenate? You want to cover that?
Yes. I don't want to use the word ventilate. I would more so want to use the word to wash out. So as we were talking about, that little bit of pep that this device can deliver kind of stints those airways open, and then that high flow is able to help wash out the CO2. So I don't want to use the word ventilate and implying that there's a shift in pressures, if you will. I don't know if you do agree with what I'm saying, David, but I don't want to actually use the word ventilate. I would rather use wash out.
Yeah, so I agree, there's not much benefit here in CO2 wise other than, you're washing out the dead space of the upper airway. So there is some ventilatory help in that, but this is not positive pressure on inspiration that augments tidal volumes, although in COPD it's been reported some of the small augmentation in tidal volume with high flow scanning, but it is not meant to be used in your hypercapnic respiratory failure patients in that group. But you may see a small ventilatory benefit. If it is going to benefit them, that means you want to use it early. So while those pHs are 7, 3, 4, something like this, there may be more of a benefit in that range. We have another question here from Joyce, and Joyce says, I work in home oxygen or home health here. Will this be something I can use for home care?
Yeah, there's new products coming to the market actually right now that are great for home health care, and actually you can look those up now, and it's great for home health care because that is why we see a lot of admits is they're coming in because they've plugged and they've retained their secretions and they've gotten a bug and they're sick. So this is a way to basically help offer that humidity and that heat, which will hopefully keep those airways open and they're able to cough up what they need to cough up. I think it's a great use in home health care.
Around some of the same patient population, especially if you have DNR patients at home or terminal patients where you're having trouble maintaining oxygenation, they want to be with their families, and you've started your palliative care and so forth, then I certainly think that high flow nasal cannula has a use there too. All right, so I think that's all the time we have, and so we'll turn it back over to you, Emily. Thanks for everyone for participating. Thanks for the great questions, and look forward to talking to you again soon.
David, thank you, and Megan, thank you so very much. The material that you've covered with us today is so critical in learning about the importance, usages, and maintenance of high-flow nasal cannulas. We can't thank you enough. And finally, last but not least, I'd like to thank each and every one of you, our guests in the live audience today, and as well as those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.